Dr. Vivek, ki whatever would be the situation, but Dr. Ashish will always be very cool. That smiling face never goes off. Big show, Dr. Ashish. Good show. A very good evening. I'm Dr.Gyan Ranjan, currently working as head of the Department of Orthopedics, Uresta Hospital, Ranchi. And we have with us my friend.
My name is Dr. Vivek Shankar. I'm an associate professor in Department of Orthopedic at All India Institute of Medical Sciences, New Delhi. And as the case goes, this is an open house. It would be an interactive session. You can ask questions, you can answer the questions also.
Yes, so that we can share some of our knowledge. The X-ray is there on the screen. So first,
So this is a 20-year-old male patient presented with fused hip. As it says, the brochure says this is for PGs. So I'm going to ask the PGs if they are present over here, what are the things that comes to your mind when you see this X-ray?
any of the postgraduate students sitting here, please do reply. Anything? Anything right or wrong? Please come up.
So I'm going to ask the chairperson, sir.
Sir.
This is a 20-year-old male presented with fused hip, ankylosing spondylitis. In the pre-operative planning, what do you think is important? Are the things important in this case?
The most important, apart from the radiology aspect, I want to see the patient clinically, because I want to know what is the deformities, basically, what are the other joints which are involved in this case. Especially if you see ankylosing, how is the spine, what is the cervical spine is also important in this case. What other,
So you
I
want
would
to
say,
mention that
the
spinopelvic
yeah, spinopelvic as well as
parameters
the
are very
deformity
important when
per se.
you plan to do a total hip replacement surgery.
Whether it's a fixed deformity, fixed flexion or a abduction, adduction, what type of deformity it is, whether we are going to do it simultaneously and what, or one at a time, and what is the position on the operating table, that is also important. So all these needs pre-operative clinical analysis.
Sir, I was coming up with that question to you. He said, will you do it in one sitting or two sittings?
That depends.
Yes.
That depends on the situation, what type of deformity you are presented with.
Okay.
So in this case, there was no spinopelvic deformity as per se, though the lumbar lordosis was completely obliterated, but there was a flexion deformity of the hip joint, both about 20 degree and adduction deformity, as you can see on the X-ray, about 20 degree. The hip was fused, the knee was okay in this case. So now, in this scenario, when you plan the surgery, what are the different things that you think of? Dr. Anup?
No, Rishabh, Dr.
Oh,
Rishabh.
Dr.
tell me.
Rishabh.
Regarding planning of the surgery, as is a fused hip, we probably, regarding pre-operative planning,
Yes.
pre-operative planning,
Probably which approach you will use and
Posterior
what all implants will take, those all things we ask.
yeah. Priority will be, my approach will be posterior Moore's approach, which I am mainly using it. Position will be lateral.
Sir?
Yes, right. Rishabh, please proceed. Absolutely.
this is
Harding's
an
approach you are
open
saying.
house, you can add,
that
sir.
is the right thing what you are saying. Absolutely. Even me, what did you do, sir? In this case, how?
I
which
would ask
approach
the
will you-
house first, then
please.
we'll get to the
We have
other
a
part.
big
So Dr.
orthopedic
Dillo
surgeon
is
from
there.
that.
I think he
Oh,
can
sir.
add something to this.
Sir, please. Sir, please give.
So, this is very difficult. First, to approach from the posterior side for this hip, I do osteotomy first, dislocate, and then by piecemeal I remove the head normally. And then usually, even if it is ankylosed, we get a slight space where we can see that this is the margin between acetabulum and femoral head. Usually we...
While removing the stubulum, you want to
Yes,
say?
yes.
Okay.
That's it.
So, sir, as sir has said rightly, we'll have to plan it accordingly. The patient, whether you want to do it in one setting, both the hip in one setting, or alternatively, giving some time to it. because in these cases there would be extensive bleeding that you'll have to expect, and you have to be ready for that once you take the cut, because it's an inflammatory arthritis. Secondly, dislocation would be difficult, so we'll have to plan it that because there is a flexion deformity at the hip joint, the cut at times are difficult to take in the neck, and sometimes the when you take the cut, the saw goes in through the acetabulum. So you have to be very careful when you're doing the neck cut in these cases.
But in some cases, we have to remit also. Sir, could you enlighten us with your experience, sir? Okay.
Then I think if you, as sir has suggested, then I think when you if you have taken out the this, you can try moving the ball of the head with a corkscrew if it's possible. Otherwise, you start rimming it. And as sir said, most of the time, not 100%, but most of the time, you will get a rim of soft tissue or a rim of acetabulum margin, which will guide you towards the bottom out of the acetabulum cup. Now, placement of the cup, sir, I'm going to ask you placement of the cup. Why it is important to keep an eye on the placement of the cup, and how would you do that?
So the most important here to recognize the spinopelvic deformity, whether the spine as well as the sacroiliac joint, I think it is not fused here. So that is probably mobile, yeah. So that is the one part. Now, as far as the removing the head, the resection of the head is concerned, I would prefer to remit in situ. That means I will take a piece of bone in between, the neck resection, intercalary resection I will do, and then I will remit directly. And here, the important fact, we have to have a C-arm. Intraoperative C-arm is also very essential, especially when you are not sure. Somebody rightly pointed out that there is a small amount of fat pad where you can, the pulvinar fat, where you can identify that at least you have reached the acetabular floor. And then the tal, you have to have a note that in most of the cases, the tal is still preserved. So in that will also help us in the orientation of the cup. So we try to keep the cup parallel to the tal. And then all these things pre-operatively you have to plan also. Where will be your placement of the cup, how deep, how much you can ream. All these things is the pre-operative templating is very essential in this case.
Sir, I would like to visit sometime to Bhubaneswar to see this miraculous surgery by the meticulous surgeon. Sir, only one question is, other than this, do you have any other way out? How do you take out head? Only one this way, like making osteotomy and you remit and you take out the corkscrew. Any other way out?
See, unless or until there is some movement still possible, once you try to move the limb, you see that some movement is still possible, then it's okay. Yes, so then you can probably dislocate also after removing, doing the capsular release and all these things. I am a lateral surgeon, so I'll approach this through the lateral way. I am not a posterior surgeon.
Yes,
so
of course.
I think the message is that one, you should go through the approach where you are maximum trained. Absolutely. So I will not use any other new approach. I will go for the lateral approach. And if need be, sometimes you may have to be prepared for a trochanteric osteotomy. Sometimes, very rare.
Yes. So as sir has pointed it rightly.
Sir.
Yes, please, sir.
Please, sir.
For placement of the cup, usually I place femoral component trial, and then I put a trial in the acetabulum. I see the combined antiversion and everything, and then I rotate with the trial on both the sides, and I see where the cup is rightly placed. So I mark that place and then I put the cup.
Sir, so would you go with the normal antiversion when there is the hip is not fused, or would you decrease or increase the antiversion initially before you take it to the C-arm?
I don't use C-arm because I do posterior lateral approach and it's very difficult to use C-arm in that position. If you are using an anterior or anterior lateral, then you can use. But if everything is just like SI joint and spine is okay, then I go normal.
So because we are doing the first hip right now, the hip is still flexed. It is still flexed a little bit because the other limb is not mobile.
one should not go for the first time in this first hip. He should do normal hips first.
So my experience says that if you don't keep the anteversion too much, so Janley has written that no anteversion is less anteversion. But if you don't keep the anteversion too much, if you reduce the anteversion in the first hip, then maybe you're more protected and not giving an extra anteversion because of the already flexed hip in angstpond.
I have seen anterior dislocations also sometimes. So anterior dislocations also even in normal hips, sometimes you try to prevent posterior dislocation and it occurs interior. So one should be careful in both the sides.
You ask a question?
Okay. So, one question, like when we are doing both sides, particularly, Patna sir might reply to this case, when we are doing both side THR, what do you do to, what steps and what protocols we should follow so that both sides is almost equal, the geometry of both sides becomes equal, almost, because it's very tough, I hope, to get same geometry.
The first thing I pointed out is that what is the position of the patient, because whether I can put the patient in lateral position or not. If somebody who is having a abduction, bilateral abduction deformity or and flexion, it's difficult to put it on the lateral. So you have to go for an anterior approach if you are an anterior approach surgeon. In that scenario, you probably can think of doing both sides together. But in this case, these are difficult hips, so I'll never advise that one should go one at a time. But if it is not possible to do one at a time, then only you can go if you are an anterior approach surgeon. So that is one thing I think the other house will...
So we have now placed the cup. We are planning to do the stem. At this point, when you're reaming the stem, when you're broaching the stem, what one thing that you think is important? To maintain the length of the limb. Because the first limb will determine the length of the second limb, and you would like to give both the limb the same length. So while doing this case, the three things that are most important is that do not over-rim the acetabulum. In the first hip, keep the anteversion the acetabulum on the lesser side, not on the higher side. And third, while you brush the femur, take the vertical offset, note it down, and horizontal offset, because you are going to give the same vertical and horizontal offset while doing the second limb.
So I think we can be slightly liberal with the first hip, because that will determine your second. So
hip, exactly.
Once you have done your first hip, you have to match it to the first. Yes. So that means you can be slightly liberal. But again, the cuts have to be absolutely at the levels.
This is the immediate post-op X-ray which we had.
The another thing I'm concerned here is to put a cemented or an uncemented stem, because what I see here is slightly thinner cortices, wider medullary canal. Yes. So I will still have my cemented stem back up.
Yes.
Because these patients might not have walked for maybe so many years. So these could be osteoporotic in nature. Yes. So in this scenario, backup of cemented stem has to be there. Otherwise, you can easily fracture it.
Any question from the house?
Well, one last question, sir. One last question. Like 2 sessions, 2 hips, what should we keep in mind that the maximum geometry is like almost equal? If we are doing it in 2 sittings,
yeah.
So there shouldn't be much difference. So
see, the most important is that you have to see all the balance. Basically, the soft tissue balance is very essential. So I'll not leave anything lax. So it has to be absolutely all right. I don't mind if somebody has a 1 centimeter here and there discrepancy, but it should be absolutely balanced. If I am in doubt, dual mobility could be an option.
Absolutely. I think Ashish is not present here. I would have asked him the planning he would have done for this hip with the robotic surgery. This is the post-op X-ray of this case. So coming to the second case, Dr. Rishabh, what's your take on this?
This is a case of left hip protrusion with the central the head of the femur is centrally placed. In this case, I'll be planning for two techniques which I can sandwich technique, a bone graft which the head has come. I can put it and use a cage to prepare the acetabulum cup, and an extra, sir, anything, sir.
Uh, Sir, how will take out this head? If while doing what approach should we? Sir, we can start from the house. Our senior members are there. How to take out this head?
I don't know. I think we shouldn't take out this head and let it be there. No, I mean to say, just build bone, probably a cage. It will act as a bone graft. I don't think we should chase this bone out because you will have a big cavity, intrapelvic. So I don't think you should chase this bone out. I think just leave it like that.
Exactly.
And you can put a cage, and over that cage, some mosselized bone graft, and then put a cemented cup.
Sir, your take.
Take out the head, slightly freshen the lower part base, and then put the graft. I don't think there is a need of cage. You can fix the head cemented with the impacted bone grafting. You can put the cemented head with that only.
Sir, how will you proceed?
Okay, good question. So basically, this would be a problematic case because dislocation would be tough. So probably first of all, we will open it up, and the dislocation would be tough and sciatic. This must be lady. No. No, no, quite not. In ladies, 14% of the cases, the sciatic nerve is aberrant. So one problem. So probably we'll do in situ osteotomy.
Maybe this it's a fracture.
In situ osteotomy.
Yeah.
Now, second problem which we'll face in this case is taking out the head. So taking out the head, there are multiple options. First, you should try out with a simple corkscrew, but it will not come. So then you should cut it with in situ, take it out somehow. Another option is there in which you start rimming. So suddenly you start rimming, and you'll find the cartilage envelope which is on the medial side, which will come this side. But you have to take out the fragments. Then you have to assess the anterior posterior column. So that has to be done and classified according to the AAOS classification. And then you have to, you can see if there is a medial defect, you have to reconstruct with a mesh if required, and then do bone grafting, take out the hip center to the teardrop, iliopectineal line teardrop, and you have to do impaction grafting. I would do the same thing. So two things I will tell you. One, impaction grafting, special method of wafers, grafts. It's been described by me and it's published in, that is published in Journal of this Asia Pacific somewhere. It's published. Singh sandwich technique, they accepted, so I am happy. So that is a good method. So I did, I think, 23 or 25 cases, 4 years follow-up. Second is,
What do you use for that between the two grafts?
see, what will happen, the medial side would be, either it will be deficient or you have to put a mesh. Then we put some graft, which is with a mill morselized, then wafer, then again graft, then wafer. So it's like burger. So you do it like that. Yes, sir. And then you punch it. You have impactors which can be made, custom made and taken. And second thing, these types of fractures, a case of 55 neglected acetabular fracture recently got published in SICOT journal, 5 years follow-up. So in that I have very well described how do we manage all the cases. So probably I will do it like that. But what is the sir will say? Will
So
be best.
bone stimulants, have you been using these bone stimulants which is in the market instead of draft anywhere?
The Bujibun.
Huh.
We are not happy. I am not happy.
That's what.
In SIOR Sancheti we had issues.
Experience with Cerament?
Sir,
Cerament.
No. Cerament means?
It's a bone substitute which gets
No, no, no.
absorbed.
No, no.
It get absorbed and is
No, no.
from the-
Here in PR, the patients are very poor. Even if you ask to get Bangalore, Ramaya, they supply oleograph, autograph, we can't buy it. But yes, we'll get a CT scan.
You need a CT scan because you need to see this is a post-traumatic situation. So what is the columns? You have to
Yes.
see if there is a fibrotic union and probably you are going to remove this fibrosis and all. So I think a good pelvic acetabular surgeon can deal with it first and then in the second, because you're only 22-year-old.
No, sir.
So-
Sir, I'll tell you, in these cases, you have to go at once. Now, once I was in Korea and I was presenting similar cases, they asked me one thing, that who does pelviacetabular in your hospitals? I said, everything in India, we do it. So I am actually doing pelviacetabular as well. So if the posterior column is deficient, you can stabilize it, fix it with in situ Mata plate or recon plate. Now you have another good option, that is the DePuy peripheral locking heads, locking screws. So I think depending on the size of cup, number of holes are there. And with that you can have the central multi-hole.
The concern is only if the CT scan shows non-union, then that is the point.
Yes.
Otherwise, I will straight away go for it, multi-hole cup with lot of screws through that will hold.
Yes. So, but I would be very happy, this month it should be published, 55 cases like this, 5-year follow-up, published in CCOT.
Yeah.
So many records are coming with you.
Huh?
Many records, new records are coming with you.
No, no data, just keep reading.
So your take on bone stimulants, how do you feel? Should it be used or not?
At the age of 22, so the young patient, I don't think it should be used.
And the other ways, like the
Elderly patient, probably osteoporotic bone, then definitely it should be used.
Dikha di.
so and now
This was
Wow.
done.
They're perfectly done.
So what we did is we tried to take out the head. We took the neck cut. We tried to take out the head, but because there was a bottleneck in the head, we didn't want to ream it. So we fixed it over there. We used an oversized cup over here, if you can notice, so that there is a peripheral fit, and we could come out with.
I'm missing Dr. Vijay sir from him.
Vijay
He
sir
would have
would have-
told that you should have put one screw here. In the issue.
Multi-hole cup, at least 3 to 4 screws.
He would have told, he once called at Gujarat in presentation, he also told us, I remember. Vapi. Yes, sir.
So we're gonna get one last case.
Hey, keep on going, no tensions, please.
Ashish.
हम क्या? We should ask anybody from the audience. Yes. See, I have PGs here.
please, young guys, please say, please speak something.
This tallest guy in this
See, I don't want to call your names from here, please. I don't want to make this a lecture theatre. Request you all, please stand up and say something.
Say something.
So you can tell the clinical history of the patient. How old is the patient?
So this is about 45-year-old patient. He had presented with this X-ray. He had had history of trauma about 6 years back. And this is the X-ray that we have got. And there was some pus discharge present when he was presented around the incision, previous incision. He had a history of multiple operation about 3 times. So this is it.
So this is a case of like neglected neck of femur fracture, neck of femur plus shaft of femur fracture most probably. So it's a case of neglected neck femur and with presents with discharging sinus. So in the starting I will go for like AP X-rays there and normal blood parameters I will go for them. And my approach to the operative approach to this patient would be most likely the removal of the implant, that screw and the nail, followed by application of cement spacer in between. I will check active infection is not there or not, and followed by debridement. I will initially go for a cement spacer, like we can put it inside, like in the shape of an implant, with removal of that head. That would my initial approach.
Very wonderful answer. Seriously, you have answered it right. Just I want to know, do you know how to make that cement spacer? Please elaborate, because that would be very comfortable to the public.
Actually, I've never seen that, but I have seen, we get a template of that actually. The shape of that implant, we get template and we can put it the.
Sorry, is RPG. So what do? We have cemented molds available, PHR molds. So we fill it and we take it out and put it there. So I use articulating spacers for knee, and one patient is there having 90-day galloon and Zimmer, Hallacos.
You can use it.
At the end, I will show you my style, how I work with the poor people.
So intraoperatively, that's your intraoperatively thing. But I'm most interested in the preoperative planning, which is, I think, is most important in this case. So before you decide or plan out any surgery, what is one thing that you want to rule out?
Any active infection, that is more important.
But you said that a discharging sinus. I said I will go for the blood reports initially, that CBCSR, CRP, the total count and all.
Sir, would you do any aspiration and go for any culture before we, take up this for surgery?
Actually, the patient already must have got a lot of doses of antibiotics. Mostly the culture reports come as no growth only. So that is a problematic thing every time, because already a lot of antibiotics they have taken. That
If
is
the
also
patient is taking antibiotic and you want to do it, would you stop the antibiotic for 2 weeks or two, and then do an aspiration again and then decide upon whether to use what kind of antibiotic during the intraoperative and postoperative period?
yeah, sure, I will do it.
Good, great. Nice.
Now,
So, Dr. Vikas Anand from Dhanbad, your take, the giant arthroplasty surgeon, please speak. Welcome to AMC.
Thank you, Dr. Gyan. So I will do exactly the same as told previously by my colleague. We will do first rule out the infection by clinically and by pathological test, and we will do if patient is taking antibiotic, then we will put off for him for 2 weeks at least, and then we will go for aspiration, and if we intraoperatively we also get aspirate from all around the tissue from synovial, and then go for culture and sensitivity, and we will put antibiotic cementing spacer, and
so the house is now decided that this is 2-stage surgery.
yes.
Is it?
I think it is good to do a 2-stage surgery. First, if it is possible, to stop the antibiotic for at least a couple of weeks, and so that something grows, that it's whether a gram-positive or a negative infection or anaerobic culture. All cultures have to be done. If it is you can do aspiration, it is okay. But if the patient has already taken a lot of antibiotics, there is no point in aspirating it. The question is, we have to immediately give stability to the patient. So our goal is, you have to remove all the implants, take intraoperative cultures, and then if something grows from that, give adequate IV antibiotic, give a cement spacer. The question is whether you want to retain that head or not. You have to remove the head, because we have to give a spacer which will incorporate both the acetabulum and the intramedullary femur. So it will be a spacer, and then probably in 6 weeks' time, you can revisit that. If everything, again the aspiration and all the blood parameters are normal, then you can go for a second surgery. And that will be most probably a total hip.
Okay. So what we got done is we got an ultrasound in this patient done, and we found that there was a very superficial pocket where the pus was coming out. We got an bone scan done to look for the vascularity of the head, and we found that the head is not vascular. So there was no point in retaining this head during the first or second procedure. Now, we gave the antibiotic for about 2 weeks after getting a culture done, which came positive. And then there was no discharge present for about 4 weeks with a sequential ESR and CRP was within normal limits. So, but the X-ray looks exactly same now. Now, do you think we should go and do a one-stage surgery or two-stage surgery? Sir, from you. Sir.
Always I will prefer to go. First I will take out everything, debride it, clean it thoroughly, nicely. And according to the culture, we will put our patients on antibiotic and wait for 6 weeks and then plan for reconstruction
So
surgery.
the
PHR
patient has
surgery.
already no discharge, ESR, CRP within normal limits for 4 weeks.
For 4 weeks at least.
Yes.
And then we can go for surgery.
We can go for surgery.
Go for surgery.
Right, sir. So,
With the implant in, it's a foreign body after all.
Implant is
So,
a- yes.
even if the culture or everything is negative, but still you haven't removed the implant.
we have not removed
So
the
implant itself,
and if the implant is there, the biofilm would be there.
Yeah,
which
biofilm
would be,
is there and-
which would be avascular and it would be full with all the kind of bacterial or culture positive things. So a thorough debridement would definitely would be required. So now how would you approach the case? We are going to do a surgery tomorrow morning.
so that means all the implants have been out and
No,
it's
no, we're going to do a surgery tomorrow morning. Pre-op
it's
planning
two-stage-
today.
no, no, two-stage surgery for me. The implant will come out, thorough debridement, antibiotic-loaded cement spacer, and probably I have to go slightly deeper, so maybe a longer stem, antibiotic-coated will be better. And then probably also in the soft tissue, I can use stimulant along with that antibiotic-loaded stimulant pellets. That will give additional support. But most important is culture, that you have to know the organism.
Absolutely.
If you know the organism and the appropriate antibiotic, and I think within 6 weeks you can do the second stage surgery.
You agree with, everybody agree with that? Yes. Apart from sir was for one stage surgery because the culture was negative. There was no discharge for 4 weeks and ERCRP was within normal limits. Sequentially ERCRP was within normal limits. So sir is for one stage surgery, just as for two stage surgery. Right. So we did this. Any comments, sir?
Looks okay to me.
So maybe I got lucky with this case. We got out with this case primarily because there was no lytic lesion which was there when we were doing the debridement, and we could take the implant out completely. As I said, there was the culture and sensitivity was negative for 4 weeks. There was no discharge. The ESR CRP was sequentially within normal limits, and so we planned out a two-stage surgery, keeping in mind that if we do not find any active pus in the during the intraoperative finding, we would go and do a first-stage surgery. So the beginner's luck, but.
One question I'll ask. Sir, if there is no infection and a failed PFN, how would you go for one stage or two stage surgery? With a failed PFN, if there is no infection, that would be a one stage or two stage surgery? That would be one stage.
So, but in this case, because there was a sinus, you can never be sure. Even if you can have a sinus again after say 1 year or 2 years.
So I'm going to give you, I'm going to show, sir, I'm going to show you the pre-op X-ray right now, and I'm going to show you the post-op X-ray right now. Did we miss something? So for the PG, this was for the PGs. Yes, this was for the PGs. Whenever you see an X-ray, you have to get an X-ray of the lower and the upper joint. Otherwise, you're definitely gonna miss something. In this case, we did not miss it. We knew it, but for the PGs, there was a fracture in the distal end of the femur, which was united. But we needed to know the extent of the fracture, and accordingly, we have to adjust the length of the stem.
Just 2, 3 photos, which the doubt always comes to me. I'll well, just 3, 4 minutes, not more than that. Please do guide me because I never got answers to these questions. While I was working in Bokaro Steel City, one day a nursing home called me for an old patient. That old man was very weak, grossly he was very weak and thin, and they were very poor. And I went there, he had 2 daughters, and they told me, this evening, could I do something for him? And this was his situation. Will it come? Can you start it? Yeah. So, looking at him, his general condition was very poor, and I don't know why it's not coming. Coming. It might take some time. It's okay. Carry on. So I tried. I gave him dressing for 2, 3 days, but I had no answer to this. I always take this photo whenever I go to any conference, and I ask this, what could I have done? Anyway, I think that patient never came to the hospital again. I just thought he might have died because that was a bilateral fracture, and they don't had money for the treatment. But in normal case, if we encounter anything like this, how should we proceed? I have few more things, photos of this. This is the X-ray. I'll come to this. Sir, I'll surely, I'm just showing you a few things what I have. Yes, sir. Thanks. That answer I got from Dr. Sarnendu Samanta also. Yeah. And he told me the same thing while I was showing this in AOTS. But I carry this and I get the same reply to call plastic surgeons. Anyway, I never had the follow-up this patient because after 5, 6 days, I don't know whether he died or whatever happened, they were not having money and nursing home didn't keep him. Just, can I have another?
So on a lighter note, I would say that I will take Dr. Gyan's number and refer the patient to him.
Which one?
He has more experience in this than I do.
AMC. ये वाला है क्या? हाँ. I like to go like from post-op X-ray. I'll go back in this. This he's an old man, 75-year-old around, having cardiac problems. His ejection fraction was 35%. He was in acute renal failure. He had some renal problem, not in failure, but he was on medication. And he had a failed DHS non-infected. After he went for a neck of femur surgery, and DHS. And then he came to me. And I tried, and this is my post-operative X-ray. Any eventful thing which could have happened during surgery? Why I put this SS wire inside? Okay.
Could be a periprosthetic fracture.
I did it, sir.
Yeah.
Actually, introp. What happened? While taking out the DHS, one screw broke inside. I thought I could rim this and put that screw in the canal. While doing that, it got fractured. Then I had to open it again. Now I can start it from here. This was the shortening present, and we started the surgery. Everything was going good, and we thought we were rimming the canal, and we thought we are ready for it, and suddenly My assistant told me this, ki, sir, I don't feel it comfortable. Himda has experience of around 35 years. And I said, he told, and then I said, bring in the C-arm, and I saw that I have reached the cortex. Because I just thought if I take out the broken implant, other thing, I can put that broken part inside the canal. But it broke the cortex, and then finally we have to enlarge our incision, make the incision larger, take that SS wire, folded it, then we gave the trial one inside, and then when the trial one was fixed, we took it out, gave the cement, and we really had very little time. So everything was very fast. And finally, it happened like this. Still, that screw is inside, but I don't think it's not coming in this, might be behind posterior somewhere.
If there is a periprosthetic fracture, do you think only the wires will suffice, or you could have put a plate to augment that?
Sir, absolutely, sir. I could have plate. I should have put a plate.
You may not be prepared. for
I
that.
was not prepared for it. I should have put the plate. That would always be a better option. And but I never had that plate, and I was working in a not in a very with not small hospital. It was not a big corporate hospital. So like where I could get everything on
Actually,
time.
I would just tell one similar case in which I was trying to do a intertrochanteric fracture, a very comminuted intertrochanteric fracture, where I was trying to put a uncemented stem from Smith and Nephew. That uncemented stem, I was the only problem was that with the last impaction, there was a crack. So I could feel that I had made some defect. So immediately the C-arm picked up that there was a fracture. So I waited there in the OT for the next 1 or 2 hours and ordered a plate and then put a distal locking LCP and bypassing it with screws as well as wires. So because we cannot do a half-hearted thing, I know that I have created an intra-articular fracture there just at the tip of the stem. And I was trying to give uncemented. So the problem with these company people are that sometimes they don't have all the sizes and you have to be accommodative to them. And for that, I have to put one size bigger. I was not very comfortable. But with the help of C-arm, I was trying to hammer it, seeing the C-arm picture so that I don't fracture it. But ultimately, I fractured it. So I waited in the OT for almost 1.5 to 2 hours. Plate had to be autoclaved and everything, and then fixed it.
So this is a 75-year-old
Otherwise,
patient.
you could have done a two-stage.
Absolutely.
Two-stage.
According to this, is a 75-year-old patient with a CKD with a, there is cardiac ailment. So would you have thought of some other implant in this case?
I think, see, you had a failed DHS.
Yes, sir.
Yeah.
That's what the screw broke in while taking out the third screw broke. That was a failed DHS done around.
So most of the CKD patients, the bones are osteoporotic. So in this scenario, I do not prefer the uncemented stems normally. And because I have to bypass that fracture site, so I'll put a long stem. So I think you have correctly done that long cemented stem. The only thing I'll be concerned is while reaming. Because elderly people, if you are not reaming in appropriate direction, and you can also use the C-arm intraoperatively to see whether you are directly in the canal, because the reaming is also very essential. Because the stems look slightly varus, there is some varus element in that stem, if you see the previous X-ray. And those things, because you have to also encompass that there is some amount of femoral bowing which occurs in the elderly. The femoral bowing. So once you are putting these type of straight stems, sometimes they hit either anteriorly or posteriorly, because you have to be careful, because they don't have that same anatomical angle just like your femoral nail. You get those in the uncemented stems nowadays with anatomical stem. But the cemented stem, they are usually the exeter type, they are all straight. So you can very well hit the anterior cortex. So that you have to be careful, use the C-arm both laterally as well as AP and lateral views. Yes. So that could also, especially during reaming, because soft bone, CKD patient, usually soft bone. So very careful during reaming. That probably could have saved.
Thank you, sir. But just one last question for Ashish. Would you consider a bipolar in this case, cemented bipolar? Just one last question. Thank you. Thank you very much, sir.
Thank you. Thank you, sir.
Thank you, guys.
So we end the session here. I would like to first felicitate my friend, good friend. Actually, we came out to see school friend to see DDLJ, I think, together roaming out. We came out to schools and Michael's. So may I request Dr. Prakash Dhilan sir to please felicitate. Dr. Vivek is faculty at AMC. सबका एक फोटो भी होगा सर इधर बीच में नहीं मैं नहीं आ रहा थैंक यू May I request Sir Prakash sir to kindly felicitate Dr. Sanjeev sir for chairing the session and please come sir. आप आइए. Small token of photograph while you being on the stage. You're welcome. May I request Dr. Sushil Singh sir. Thank you sir. And Dr. Rishabh, please. Thank you. So I thank you, Dhilan sir, for thank you. एक मिनट तेरा हो जाए. One more. May I request, sir, this way, sir. Yes, sir. Sir, with this, I officially close this day. We are on 5:17, right on time, I believe. Now we need 2 hours time to set up the hall for a gala musical evening. I welcome you all for the grand gala party dinner, and we'll be having music the music and snacks this side, and dinner will be in Kesaria Hall. So I request everybody to kindly be here by 7:30ish, 8. And tomorrow again we'll have Sorbonne session on the robot, 9 to 10, and 10 to 11, Dr. Adarsh and myself will be demonstrating a live Mako robotic surgery. In the afternoon, we again have a robotic surgery which is being beamed from Calcutta. That would be a Merrill Cubis robotic system to understand the basic differences. And a person speaking on the Cubis system. And then we'll shift over to the revision scenarios. So thanks a lot for making this day a grand day. And I hope you enjoyed. And I'm thankful to each and everyone for sparing your valuable time, coming and sitting here for the whole day, listening to things. Thank you, sir. He'll say something.
I just